Welcome, everybody, and thank you for joining us here in person, and thanks to all of those who are joining us on the webinar. As Peter mentioned, I'm going to talk a little bit today about some preliminary findings, a study that we've been conducting, looking at some of the challenges in accommodating mental and physical health conditions, and what workplace parties are saying. Why is this an area of interest? It's an area that's getting a lot of attention for many reasons, but just a few statistics to start us out. As of 2014, nearly 40% of Canadians reported that they live with one of 10 major chronic conditions. And about a third of Canadians report being limited in their daily activities, sometimes or often as a result of their health. And so with changing demographics, there's discussion that this is going to increase. This is not going away. It's something that we need to deal with. When you look at the most costly groups of conditions, and by costly here I mean the direct healthcare costs and indirect costs related to things like absenteeism, we find that in Canada, neuropsychiatric disorders come in at about $12.5 billion a year, cardiovascular diseases about $12 billion, musculoskeletal diseases and musculoskeletal injuries, which are very common as well, are actually a separate category. So these are MSK diseases like rheumatoid arthritis and osteoarthritis are at about $7 billion a year, and then digestive diseases, things like inflammatory bowel disease, at nearly $6 billion a year. So very costly. When we separate out some of the indirect costs like to things like absenteeism, we find that the projected costs range from about 0.8 to 1.4 billion every year in Canada. It's a lot of money. The real costs to the workplace and workers are often higher because the report doesn't include costs related to presenteeism, so like lost productivity, or all the costs that employers and workplaces incur in terms of changing jobs and retention, replacement costs, and costs like underemployment, where people with a disability aren't able to fully utilize their skills and their education and are underemployed. Other research then often estimates total costs for any condition at about 60 to 70% of the total costs of the disease. The various conditions here are really very different in terms of their causes and how they're treated, but there are a lot of similarities with many of the most common conditions that we have in Canada in terms of their impact on work and in terms of some of how they are exhibited in the workplace. So for example, many of the most common conditions that Canadians live with are really what we would call episodic conditions. They're chronic, but they are intermittent in terms of the disability or the problems that they create for people who are living with them. They come and go. People talk about flares or episodes. They're also often invisible. So signs and symptoms of the condition are not readily apparent to others. Looking around the room, you may not know, you don't know who in the room is suffering from ankylosing spondylitis, anxiety disorders, irritable bowel syndrome, and so on. And so signs are sometimes more apparent in the middle of a flare, but often we don't know whether someone lives with these conditions. And they tend to be unpredictable. And by unpredictable, I mean that even when people are following treatment guidelines, taking their medications, they may still experience a flare or an episode. And that makes planning and managing the condition and planning in the workplace then also very difficult. And I've listed a bunch of examples here at the bottom of the slide just to show you the range of really how diverse these conditions are, but that they all share some of these characteristics. What this does in terms of the workplace, of course, is create a number of challenges. Workers can be uncertain whether, when, and what to share with workplace parties, and many people don't want to share any information about their personal health. Privacy legislation, of course, protects individuals in most of the provinces, in all of the provinces, from having to disclose a disease diagnosis and often symptoms of the condition. The focus is intended to be on activity limitations, but for workers, they don't know what they don't know what this means. How is it that I'm supposed to open up a dialogue if I need something? And of course, workplace parties may notice changes in a worker's performance or unexpected absences, but be unsure how to go beyond and broaden the discussion so that it's not just about performance deficits, but to find out if there's something here that needs to be done and support needs to be given. And of course, limited information can make workload and support accommodation planning very difficult for everybody that's involved. So, just to sum that, these episodic, invisible, unpredictable conditions creates challenges in balancing protection of privacy. We would never say people should have to disclose, but in balancing then protection of privacy and fostering communication to provide support. And in terms of meeting needs for support and accommodations while protecting or while maintaining workplace productivity. So that's the area that we wanted to move into to gain more information from various workplace parties. In terms of just finishing some of the background, I want to use an iceberg metaphor because we're the Great White North, and why not? An iceberg metaphor is actually a very helpful way to think about these chronic episodic conditions and how workers manage them in any workplace. And it's helpful because, as we all know, icebergs often have much of the ice, the dense ice, underneath the surface of the water. People don't see that. Only a little bit of the ice is often protruding above the waterline where everybody's aware of it. And that really characterizes and captures what we hear from workers when they talk about how they manage their conditions in the workplace. So if you look at the very bottom there, when we've spoken to workers and when other researchers have in both quantitative studies and qualitative research, we hear that a lot of what people do to manage work happens at home. People find they have to sustain their energy, they have to devote time, they don't want their symptoms to be interfering with work. Work is a protected role. And people will go to great lengths to not have anyone know that there is any problem at all. So what starts to happen at first is people start limiting and giving up a lot of their leisure activities. They get help from others for a number of things, household chores and things like that in the workplace. All of that is to free up time and energy to devote to work. At work, of course, you can't give up and limit as much, or you don't want to do that. And so we hear a lot about what we call anticipatory coping. People, if they have any control at all, planning and trying to anticipate what will be the problems that they will face and avoid them from happening in the first place. Again, people don't want others to know. All of those efforts can go on and make work sustainable for many people much of the time. They do create challenges, you'll see on the right, to work health, personal life balance. And so often when there is a problem, it's when it's a crisis. People have nothing left in their personal lives to give up or limit anymore, and it suddenly interferes with work. If you move up the iceberg a little bit, you see supervisor and co-worker support. Sometimes when things aren't working, this is when people now have to make this decision whether to say something. We know from some of the longitudinal studies that we've done with people who have arthritis, for example, that people are more likely to share information with at least one co-worker who they feel they can trust. And then about anywhere from 35 to 50% of people will say they have not told their supervisor. What predicts when you do tell someone? When you have a need that now you can't ignore, and also when you perceive that you have a supportive workplace. So those perceptions of the workplace are very important. I'll come back to them. Right at the waterline, you see a lot of existing policies and practices. We've done a number of large surveys looking at use of these kinds of policies and practices, things like flex time, modified hours, and so on. We actually see, again, diabetes, arthritis, and then some of our qualitative research with other conditions, people tend not to use them nearly as much as you might think they would. Part of that reason is people have intermittent symptoms, so they wait until they need them. But it's not as big as a drain as I think sometimes people may be concerned about. And then along the very top, when everything's out in the open, we have this group of individuals, human resources personnel, disability management, labor, and union folks, and lawyers. And we know very little about their perceptions on this whole kind of process, and so that is what I'm going to focus on. We wanted to understand what the key approaches, issues, and challenges are for disability prevention and support that are related to these conditions. We wanted to really understand how communication processes within a workplace facilitate or perhaps act as a barrier to disability and prevention support efforts. And we wanted to get this from the perspective of these different workplace parties. So this project is actually part of a much larger initiative. And to date, we've actually reviewed all the literature. We've conducted focus groups with workers. We're doing more of this. This is ongoing. I'm going to talk about these 24 different key informant interviews that we've had. This is also ongoing. We've done a search of existing publicly available information that workplaces might be using. And we've also worked with the Ontario Ministry of Labour to help them launch a survey to assess their own workers' awareness of and experience with various policies and practices related to disability accommodation and return to work. What we did to get our key informants as part of this study is we recruited a convenience sample of workers who, using advertising and the networks that we have here at the Institute. We interviewed people using a semi-structured interview. They're on the telephone or in person. It took about an hour. We asked about disability prevention and support roles, successes and challenges, who is or should be involved, potential contextual factors. What changes this? What makes it different? So, for example, the type of condition that you have, and any gaps in resources. We've done qualitative content analysis, and we're in the process of coding all of the data. So these are some of our preliminary findings. A little bit about who we've spoken with, mostly women. Mostly very seasoned professionals in this area, in that they've, many of them on average have been working about 20 years, not always with the same organization. Many people have moved around, but using and building their skills for a long period of time. We've spoken with a number of disability managers and human resources personnel, managers and supervisors, worker advocates and union representatives, labor lawyers. You'll see 3 there. We got lucky. We have a labor lawyer who works with workers, a labor lawyer who acts on behalf of a large union, and a labor lawyer who works on behalf of a large employer. So we've actually had different perspectives. We have a medical director and an occupational health nurse who've participated, and of those individuals, 4 of them themselves have a disability that affects their lives at times. And so they were able to give us some unique insights into that. We have a range of different sectors served, not as much in the service retail, but 4 of our participants actually worked with multiple sectors, including sales and services and manufacturing and construction. So we have some breadth there, which has been important to us, not to have everybody who's sitting at a desk with a lot of screen time. So that's been useful. What are we going to do with all this information? What we'd like to do with the key informant data and all that other material that I told you we were collecting and learning about is to start trying to map out a communication and accommodation process. So this is a very, very basic model where we've identified, all right, a person has a health condition. They make a decision to communicate or not communicate. If they do decide to communicate, there will be a response and presumably an outcome, which may be not doing anything at all. If you don't communicate, you can, of course, things happen. You may change your mind. You can go through this process more than once. It's hard to untell people something, so you don't get to do that necessarily. Although we do hear about people where management has changed, supervisors have changed, and they decide at that point to not communicate. Very simple. The first thing, of course, that starts happening is we find it's much more complex than that. So people don't flip a coin in terms of whether they're going to say something or not. They go through a fairly, sometimes lengthy communication decision-making process. When you decide to communicate, you have to figure out what to say. So there are message elements, there are multiple people who may be receiving the message, and there's a process that goes on here for the response. So what we'd like to do in future is start unpacking each of these boxes to help us to learn where we need to do more research, and also to help us develop resources and tools that might be helpful to workplaces and to workers. So just as an example, before I go on and talk a bit more about the key informants, if you look at this communication decision-making process, what happens when we pop open that box? First of all, we hear workers. They undergo a number of different things. Everybody seems to tell us that they go through this approach avoidance process. They weigh the pros and the cons. Am I going to say something or not? They may consider their rights and obligations. They'll think about their current needs and what might happen in the future. Why am I thinking about talking now? What's going on in my life? What might happen that I maybe should say something? And what could be the outcomes of this? And again, all of this will take place and be influenced by the type of job you have, the environment that you work in, your health conditions. So we know, for example, people with mental health conditions are more reluctant to come forward and say something. If you look at those 4 bullets there, they pop open as well. So there's a lot under that. What are the pros and cons? Well, people have a preference for sharing information. They'll use their past experiences. They're going to look around at their colleagues. So there's a lot under each of these. People may be unaware of legislation or have a general sense that I have a right to duty to accommodation or a right for privacy, but really be very unclear about their particular organization's practices and guidelines, and what the number of weeks are that you have where you can be on disability and so on. The current needs and goals, some people decide to say something in advance of an issue. Most wait until there's a need, and sometimes it's a crisis or others notice and out people. And then, of course, there's the outcomes. We have a lot of people who say, my job is my job, there's nothing can be done, so there's no point in saying something. So those kinds of outcomes people consider as well. Do they think there'll be a positive or negative reaction? Maybe it'll just go away. That's the other thing we hear most frequently with these intermittent conditions. Go home, get some extra rest, I'll be fine on Monday. So I want to focus, though, on this box here, the message recipients, again, what our key informants told us about themselves and about working in this area. And I also want to focus on this big blank space here. When a worker decides not to communicate, what goes on there? But let me start with the message recipients to begin. So first of all, I would say our workplace parties, and this is not news to you, they're not passive recipients of information. They actively respond to information. They shape that information. And although it's obvious, on the other hand, there is this sometimes assumption that there's a perfect playbook out there, that all the policies are written down. All you have to do is open it, find the right page, and there you go. Now you know what to do. That's not the case. That's all of our recipients agreed that is not the way it works in this area. Many of our respondents were actively working to ensure greater awareness of the needs of workers with these kinds of chronic episodic conditions with their colleagues and with the workers. They recounted a number of efforts that they were undertaking to better implement the policies and practices that they had and sustain work. And there was a general feeling that this greater attention will have positive benefits. It will help clarify the needs of workers and destigmatize some of these issues. It will help promote fairness and transparency, foster a notion of disability prevention as opposed to crisis management. And that disability prevention was a key phrase we heard from individuals, acknowledging that disability is not a problem that a worker walks around with. It's something that happens as a result of the social and physical environment that makes work challenging. And if we can take away some of those barriers, a person is no longer disabled. And it will enhance education and improve skills. So we heard quotes like, we have a number of people who have returned from long-term disability and they're still sustaining work, people with serious chronic limitations, various kinds of health conditions. I can just instantly call up half a dozen faces in my mind where 10 years ago they might have all still been on LTDP, so a long-term disability. And someone who said, I'd say for the most part, we've been very successful with it. There are still some challenges, yes. And that's what we're going to spend the rest of the time on, some of those challenges. So sorry, I just wanted to, changing the profile of the iceberg. Again, what people were really telling us was that they wanted more of this up in the light. More of this where it wasn't all beneath the surface and up to a worker to try to figure out, but where they could bring this information and help make this a better process. But some of the challenges, workplace parties obviously have different roles, power, and relevant skills. Not everyone is receiving the same message, and that creates challenges sometimes in terms of who knows what and what people can share. Individuals are also involved often at different time points, and that became challenges. So not surprisingly, supervisors and sometimes coworkers are involved early. They hear about issues early on. Disability managers and HR are often later. Sometimes people go for assistance and advice from these individuals, but there was sometimes a sense that they were being asked to play a role too late, or not too late, but later when they could have done more earlier on. And then union, although union representatives sometimes are involved early, very often they and labor lawyers are involved, of course, far down when there's some dispute. Something has become contentious. And so the union representatives also were talking about wanting to be involved earlier to train their representatives to be more supportive and play a different role. And of course, workplace parties have sometimes implicit models that they walk around with. Nobody articulated this to us, but they have a different perspective on how to frame disability prevention and support. And I've used some jargon terms that we use in research, a medical model versus a biopsychosocial model, just to highlight these different approaches. But let me show you a couple of quotes. We had someone who talked at length about a situation that evolved where there was an incorrect diagnosis and said, because our third-party providers have that diagnosis, in most cases it's a much smoother transition. I find even return to work recommendations are more meaningful because they have the diagnosis. As you know, the most important thing is that people are properly diagnosed. So very much a medical perspective here. If employees don't share with us, then we tell them that we need medical documentation. And so we're able to get at least some information. And when it comes in, if it's really, really, really brief, then we may ask the employee to sign a consent to speak with their treatment provider. Again, confidentiality. So again here, a diagnosis, that medical information perceived as very important to the process. Interestingly, our medical director said this: we only gather medical information, or I get involved in about 25% of cases. 75% of cases do not involve a medical practitioner at all for 6 months, up until they go on long-term disability. We sort of describe that as a continuous improvement thing, where we're trying to accommodate people as opposed to manage their diagnosis, which is a complete and utter waste of time. You can't explain everything by medicine, by diagnosis, and you need to find some way to be fleet of foot and manage these, because if you don't, they go sour very quickly. So a very different perspective, one that was shared by a number of our other participants as well. Why the differences? We don't entirely know, but I would speculate that from talking with some of these individuals, knowing a bit about their background, some organizations have a stronger history with the compensation systems related to workplace injury. In those situations, a medical model was often familiar. It was seen as a natural extension then of what they could do related to disability support. So we'll keep using this model. We'll now apply it to these other conditions. Where we heard more of a biopsychosocial approach was when organizations were really struggling with health professional input. They found that health professionals often couldn't provide them with the kind of information that they needed to develop a workplace accommodation plan. Workers were often struggling to gain access to the right healthcare professionals, which was delaying this process. Sometimes workplaces were rejecting the information. So for example, we had someone who talked about a person who had rheumatoid arthritis, who was very distressed and upset by the diagnosis in addition to having the symptoms. So the rheumatologist, in writing a note, said that in addition to the RA, there were also signs of depression. But the workplace said a rheumatologist is not qualified to make a mental health diagnosis, and so this is not appropriate. That one was going up to the lawyers. So again, there's this sense of it being very protracted and long, and then workers are incurring significant out-of-pocket expenses, often $50 or more every time every health professional has to write anything, and sometimes workers want this more than once. So that seemed to be part of why people were moving away sometimes from a medical model. Another cross-cutting issue that came up was this promoting fairness and transparency, which everybody wants, without a doubt. Sometimes that, though, was equated with consistency. If it's fair and it's transparent, it's the same. But what we heard from our key informants was that they don't get the same ever coming to them, and they really need to adopt a case-by-case approach. And they need that to be flexible and individually responsive. But they sometimes were getting a lot of flack from others because case by case can look haphazard and arbitrary. And so that's an issue that many of our respondents said was really creating some difficulties. And to give a slightly different example of that, what a number of organizations said they were doing, and it was also in part to deal with variable skills of managers, was to take decision-making out of the hands of managers and supervisors. Again, take it from underneath the waterline where we don't know what's happening, bring it up into the light where it can be handled by others in a, again, consistent way, which means transparent and fair. But supervisors and managers said that what often happened in those cases is that they were then not included in the process. And they really struggled with this because they often said they had the greatest responsibility for implementing the accommodations. They have to maintain productivity. They have to plan the workload and keep morale and all of that up. And by keeping them out, this was creating a problem. Workers too said too often they were not submitted information and then they were out of it and had to wait very long periods of time before someone told them whether this was approved or not. So when that happened, the perception of the process was really one that was eroding trust and taking far too much time. And it doesn't always happen this way, but it sometimes, again, for the sake of transparency and fairness and consistency, it was creating another problem down the way. So again, I've mentioned a fair bit. Subjective reactions play a part. I want to just back up and say most people told us, it was very human when you hear someone is in distress, someone has a problem, to feel upset, often to feel helpless if you were a supervisor or a coworker. Occasionally, annoyance. It's them again. They always have a problem. That kind of reaction. When little information is provided, workplace parties try to fill in the blanks and find out or figure out what's really going on. And we heard a lot about this, that it's just human nature to try to do this. And so it's not easy to balance this privacy and doing something or know what to say to people when you really can't be asking too much. So workplaces can be very caring and empathetic, but there can also be gossip and misinformation. And many workers don't want attention. And they particularly don't want sympathy. It's nice on the one hand to know you have caring colleagues, but they don't want someone every time you walk in the room looking at you like, oh, there you are. So sad for you. So, and that goes on. So they don't want to share information. So we heard, and this was interesting because these are two quotes from our lawyers who we asked very directly about legislation and whether or not sometimes it created problems. And all our lawyers said yes. In fact, all our participants said yes. They recognize the importance of the legislation. They stand by it. Absolutely. But it is, one person called it a heavy hammer to be dealing with a problem that really needed a lot of finesse. So you get the the medical note that is strictly correct, which is the employee will not be able to work, and then the return to work date, and then these are the limitations. We're not told what we're dealing with, and so the law in a sense runs counter to human nature, because I think we're much more inclined to be sympathetic and empathetic and helpful and creative when we understand what we're dealing with. And so they spent a lot of time in their practice trying to educate people, get over it. We know you care, but we've got to move beyond that. If they don't have any information, they tend to feel minimized, and sometimes employers say they feel hurt. They feel hurt that this person isn't talking to them directly. And people get curious. It becomes the puzzle of the week. They said that they have difficulty with focus, and they said that they have difficulty with this. I'm thinking it must be this. Oh no, it must be this. You just get all these crazy ideas. So that is something that people spend a lot of time often at the beginning of trying to manage these conditions or support these conditions in trying to educate everybody. Let's focus on the work and what we can do here. We do have the opposite. In some cases, everybody knows, but then that creates a difficulty for one of the different workplace parties then in continuing to protect privacy. So one person said to us, in a small office, you know how it is. People actually have relationships, and so confidentiality is out of the bag. We couldn't have tried to pretend this person wasn't away on a mental health disability. The place is just too small, and everybody saw the symptoms themselves. What position does HR have to take? Being bombarded with people wanting to know, is it safe, what's going on, what should I do, all of these kinds of issues, and feeling very trapped by there being too much information out there. So, message recipients are bringing their own experience and their history to every one of these situations. They have issues of likability and trust. There will always be work context issues, a comfort level that people need to recognize they have themselves with sharing information. I get all the time, whenever I do even surveys, but also the qualitative information, how can you ask people such personal questions? This is terrible that you do this kind of thing. And I always respond that we have a hard time getting people to stop telling us sometimes about their personal information, in that many people are willing to share and they're happy that someone is asking them about the situation and wants to listen. But people will vary dramatically on how they feel about sharing personal information. And again, there's this tension between the perfect implementation process and this case-by-case process that needs to be made. So just a final couple of quotes about the message recipients. There's some workers who just have a way about them, and they explain themselves and you hear them. Then there's other workers that are just more aggressive or demanding, and it doesn't mean that their issue has less merit, but from my years and years and years of experience, people just sometimes start to shut those people down because they can't see past their personality, and that there is a real issue here. And someone else who talked about within a workplace, the struggles when you sit down in a group to try to deal with these situations. It matters whether you start with a position of, I'm going to trust until I have reason not to trust, which is what she wanted to do, or if you start from, I'm not going to trust until you give me reason to trust. And different situations get played out differently depending on that. So, I guess in terms of what we were hearing, everybody knows people bring a personality to the table, but we think a more explicit attention needs to be made to the workplace culture, to whether you're starting with this kind of medical model and from an injury perspective and adapting it here, or whether there's another approach that can be used. Much more discussion about who's included and when. To not shut people out too prematurely and not lose them when maybe you should. So, for example, the disability managers also talked about, once the accommodation plan is done, I'm usually out. I don't monitor over time. I don't get involved again unless there's another problem. So they often depart at that point. And then, of course, recognizing and educating people about their preferences, that they will be looking around and helping people to understand some of these issues. I want to just finish up talking again, talking a little bit about the blank space that we see here. And this is when a worker has decided they don't want to say anything. They've gone through that whole process. They're not going to communicate. Of course, it's not blank at all. There's a whole lot that goes on here. And in fact, this is where, again, sometimes these get resolved very well. But when we heard about a kind of ongoing hiccups, bumps, and horror stories, They were all in this bubble here. What happens is others notice a problem. They will go through that same process. Should I say something? I don't want to make it worse. Maybe it'll just go away, that kind of thing. They'll decide to communicate or not. Not communicating doesn't mean you aren't watching and paying attention now and interpreting everything in terms of what you think is going on. But they may communicate. So again, often this starts when a workplace party or supervisor or coworker notices a worker's performance or mood or demeanor has changed in some way. And so a supervisor or manager may approach a person informally to offer support, to say they've noticed that they're not themselves, and maybe something can be done. As I mentioned prior to this, people will go through this whole process of whether they say something or not. If approached, workers don't always provide information to explain what is going on. And what we heard is among the most stressful examples that we were given for workplace parties were situations of mental health manifestations that were denied or not recognized by workers themselves. And those were often quite tragic in terms of how they got played out. So a couple of quotes here. This one individual was saying that people were talking about her. Staff would come in and do some work, and she would think that they were spying on her. And he gave a lot of examples to suggest there was really a heightened sense of paranoia here. We talked to the physician. This is one of their EAP or their providers, the psychologist about it, trying to get some information about accommodation. Is she getting the right kind of treatment? Does she need any treatment? Not knowing a diagnosis was difficult. She thought she was fine. We don't know if she was or not. But really, she came very close to being fired. This also just tore apart all the interpersonal work dynamics in the workplace and made it a real struggle then even in terms of accommodations, what you do in bringing a person back to work. And then one of our worker advocates who lives with bipolar disorder said, truly, with mania, you generally don't know anything is wrong. It's very hard to have insight when one is manic. In fact, I had some insight, but I really needed to have friends to say what's going on. And she gave some wonderful examples as well about some of the challenges around that. That's a sort of one process that can happen. In larger organizations, there's often a formal communication process that is triggered by a threshold of work absences being reached. And many of you will be familiar with this, often labeled attendance management or attendance support programs. The program, if you reach this level of absenteeism, triggers mandatory meetings, ostensibly to identify support needs. And that is the intention, to try to intervene relatively early to start to identify what's going on and make a difference. But the reality is, and our workers and workplace parties all agreed, that these really can pressure workers into disclosing something. They recast disability right up front as a performance problem. It becomes an issue of progressive discipline, not so much disability. It tends to focus then the future discussions on deficits and not the skills and abilities of a worker. And it can erode trust and confidence in the process. So it's not always bad. Sometimes this does really work out well. But if I had to pick something that was consistent among our key informants in terms of where it goes sour, as that one person told us, it's often right here. Some workers, we heard from the key informants will, and especially those with mental health issues, will rather admit to a performance problem. I am doing a rotten job, rather than say they have a mental health issue that's making work hard. And so this goes on, and now you're working on termination papers, and it's at that point sometimes when it comes out that a worker finally discloses. Which may be then seen as, all right, this is the excuse, this is the last-ditch effort to try to remain working, and so is sometimes not treated as legitimate, or it just, everything now becomes very difficult. So a couple more quotes, we're almost done. What happens with episodic conditions is that they have incidental absences. And if they pass that 10-day threshold, then a progressive discipline approach is taken with them, and that's not always the right approach to take for someone who just needs time off periodically to attend to their health. It sets up an urgency at the beginning, because usually by the time they might involve, and she said me, a disability manager, they're quite high in the attendance management program. The employee in a lot of situations is not getting along all that well with management because they're being attendance managed. It's a little harder for a disability manager to develop the relationship we need, but it does vary widely. And recall that I had said disability managers in HR often come in later in the process. They don't like it when they come in at this point. This is something they would like to, again, back up and come in earlier. So going forward, there's a lot going on. As you can see, I only unpacked a couple of the boxes here today. We think that there's a real need for additional evidence-based tools, resources, and training aimed at workers and workplace parties to really foster communication. We would not say that people should disclose, and I do want to make that clear, that we have to find something that's within a worker's comfort level and the workplace needs, and that's what we want to do. So protect privacy and preferences related to sharing, but still get what we need to get done. We think there's a need for resources related to assessing job demands and creating more tailored job accommodation plans and providing guidance on monitoring them over time. I didn't talk about the monitoring, but when you set up, after all of this work, an accommodation plan, and you go forward, and in 4 months, you're back at the table revisiting because it's not working, some parties become very disillusioned. Is this now cause for dismissal? Whereas some of our key informants said, you know what, we have to educate people that that's to be expected. We think we'll be back here a few times before we get this right, and we're going to monitor people over time so we continue to do it well. And then, of course, we want to make sure that we're meeting the needs of workers with diverse episodic conditions. Since you can't ask what the condition is, we have to make sure that we find ways to meet the needs of really a wide range of conditions and the perceptions of stigma or other issues that may be associated with them. So, related to that, we've just been awarded a 5-year Healthy and Productive Work grant to move into some of this area and to continue the research that we're doing, develop new tools and resources. We have called this project Accommodating and Communicating About Episodic Disabilities, ACED, so the ACED project, a partnership to deliver workplace tools and resources to sustain the employment of people with chronic episodic conditions. We have a fantastic multidisciplinary team of researchers who are involved, and that will grow over time. And we also have some wonderful partners who are on board with this right away. And that includes 5 health charities and various groups that have already been working with workplaces or regularly do this, who will bring their expertise. And I'm just going to tell you who they are: the Arthritis Society, the Canadian Mental Health Association, Crohn's and Colitis Canada, Great West Life Centre for Mental Health in the Workplace, Mindful Employer Canada, that does a lot of skills training for managers, Multiple Sclerosis Society of Canada, the Ontario Ministry of Labour, Realize, which is an HIV charity but has done a lot of work with episodic conditions more generally, here, the Institute for Work and Health, and the University of Toronto. Some of these groups have tools. Everyone's agreed to adapt, enhance, and create new tools going forward, so we're very excited about that. Among the things we're thinking about are a personalized communication tool for workers, templates for starting a conversation for workers and workplace parties, an interactive job analysis tool that people can work through with accommodation examples, information modules for workers and supervisors to monitor changes and needs over time, and skills training and coaching workshops for workplace parties who want to be able to provide more education for individuals. I know that's a lot of information. I just want to acknowledge the Social Sciences and Humanities Research Council and the Canadian Institutes of Health Research for the funding for this research, and thank all our key informants. Julie Bowring, who's a project manager and works on every aspect of the study. Julie and Dina have been coding the data furiously to get ready for this and will continue coding. Sarah, who's helped us with our partners, and Christina and Wynne, who've helped us with recruiting. And thank you, and I will take questions and comments.
Okay, thank you, Monique. Are there any questions in the room so far? I am happy to start with one, unless you've got one, Sarah, online.
Yes, I do.
If you could just speak loudly so the
Yes,
webinar participants
I'll kind of
can hear.
lean over. So this is from Mary, and she says, "Hi, and thank you for the presentation." She had a question about the two groups of employees who choose to communicate versus not. And do you have any numbers on? Oh, sorry. It comes up the numbers on the percent of employees who choose to communicate, and whether there's a difference in the size of the organization.
So for the first part, in terms of the numbers, it varies quite a bit, and there isn't a lot of, I would say, data on things like Crohn's and colitis, and a whole lot of conditions we don't know. For arthritis, we're hearing somewhere between 35 and 55% of people don't say anything to their employer. We hear, but I don't have numbers, that this is much lower for people with mental health conditions.
And do people tend to disclose more if they're with a larger organization or less?
We have only qualitative data that I know of on that issue in terms, so we don't have big surveys that have asked that question. The qualitative respondents, workers and workplace parties that we've spoken to, both suggest that in smaller organizations, people are more likely to share, which I suspect is less related to the size of the organization and more to a perception of support. We do know you're more likely to share if you perceive your workplace is supportive, large or small.
Okay, just if I could just add quickly to that, Mark Corbier, if people are interested in disclosure, Mark Corbier and Kate Tooth have a program at the moment around disclosure with mental health conditions and people seeking employment. Avi.
So I was thinking of that slide on manifestations and kind of things that aren't really, things are discounted from the kind of decision-making process. I was thinking of unconscious biases, and you hear about it in the physician referral process that, based on gender, based on age, based on race, a lot of these manifestations of a disease are kind of discounted. And I was wondering how that would, if you've seen evidence in the data you've collected, in terms of unconscious biases kind of affecting the decision-making process, if that's affected how the physicians have kind of provided a diagnosis, or if that's even affected the ability to communicate or not.
Okay, so the question is about unconscious biases and whether or not that affects the decision-making process, with some examples about research that have been done with physicians, issues like gender and other things that may affect whether or not this is legitimized or there are some other biases. We didn't speak to healthcare practitioners, so other than our medical director and occupational health nurse who worked within a company, so I don't have the biases there. One of the problems with doing research there is that people, if people are unaware of their own biases, they often don't tell you. Right? It's hard to ask people directly, and you'll get the, no, I never do that kind of thing. We try to get around some of that by asking people about challenges and whether, sometimes there are some workers who are a problem, or maybe there's an age group. And so we did try to find ways to see if people might insert some of these. I would say there's more room for that. I think people certainly do have preferences for a style of interacting, dismissing information. I would say we didn't hear consistent issues about some types of or groups of workers. What we did hear actually made a lot of sense. So, for example, we heard that men in some physically demanding work are less likely to disclose, some of the reasons for that in terms of culture. But we also heard that women working in those areas were even less likely to disclose in traditionally male areas. We heard people were upfront about having to walk in knowing their own biases, and And there it was less about a particular group of people and more about, this is the fourth time I've been seeing you at the table, and you're unresponsive, you're unhelpful, you're belligerent, and you're making this process a problem. That kind of, it was the experience that they were drawing on. But I agree, I think there's a lot of room here for us to be looking at those kinds of issues in this area.
Andrea?
And at the bottom of the table there. Hello.
Very interesting. And related to what he commented before, from the perspective of the treating physicians, is there any training, anything that, I think there's a lot that could be improved, because the treating physician, the family doctor, the specialist who's seeing these people, they may, if they knew, they may advise the worker when to disclose, how to disclose, what to disclose. But there's absolutely no training. I know I didn't have any training, and I know we're not doing this. Are you willing to develop some training like that? Could even be like something quick to train them.
I think,
any plans to do this?
yes. Sorry, just to repeat the question, I've been told I have, we have a lot of people online. The question was about training for various healthcare professionals because they don't receive any training in how to help a patient with communication and what to say and how they could approach this. So I would certainly say that from our perspective, we have heard from all the partners and from many of us that it would be really helpful to get this group more engaged. We do have a physician on the team, and so that is, I think, to look forward. It surprised us when we heard some organizations were moving away from this. And so I think we have to sort of try to figure out what the needs really are. I think it's the same as, we have with workplace injuries, that the physicians don't know what the accommodations are. What some organizations had been doing is they developed their own template. And so they now want that to be filled out by a physician because they're saying this is what's most applicable to our workplace and the types of jobs we have, and that they may even have a part of it filled out. This is this particular worker's type of work. Now this should help you then with the accommodations. So I think that's more where the work is rather than on helping communicate. I think what we hear there is physicians are more likely to say, you have a right not to say anything, and they have a duty to accommodate. And so we do need, I think, more training on that whole process because it's very high level and not particularly helpful to anybody. Yeah.
This is the back.
First of all, thanks for presenting. The big thing that spoke out to me, kind of jumping back to the beginning of your presentation, was age, and seeing that the employees that had been assessed had been in the workforce for typically over 20 years. And as a young person still in school, but in a big corporate culture world, I want to ask, as neuropsychiatric coming in at 12.5 billion, and we've seen an increase in mental health issues. But as a young person, we've fostered more awareness through our education systems and in our culture. So with this rise in statistic, but this greater awareness, do you think that these costs are going to continue upward? Or do you think that by getting these kids in school and practicing mindfulness and cognitive behavioral therapy and things like that, implicitly, do you think that's going to decrease the cost, or are we going to continue to see inflation?
So the question is about some of the life course issues related to mental health conditions, and that we're seeing big costs, but as we focus more on this and there is more awareness, will these costs perhaps come down because people can better manage their own mental health issues? Is that fair? Yeah. It's an excellent question. I don't know, because what we heard a bit from workplaces. Some said they weren't seeing much of an age difference. Some were saying that younger individuals were more aware and more likely to share some of this information, but it was less of a daily stress and hassles that we all face that we can control, and it was more of more severe mental illness where people were sharing, and that mindfulness and some of these other things might be helpful as part of a management strategy, but there's a bigger treatment and therapeutic process that needs to go on. So I certainly would say if they go down, I wouldn't expect it in the short term. If anything, I think we're going to see bigger costs, but then hopefully over time, we would maybe see some of these costs change and lower. I hope we don't see it lower for some of what we heard on occasion related to older workers, where there were some perceptions that sometimes it's easier just to buy them out than to deal with accommodation planning for them. And so sort of one shot at the accommodation planning, and if it goes badly, let's talk undue hardship. They're expensive anyway. Get them out. That was partly, came up a few times in our key informant interviews here. We've also interviewed a number of workers who are over 50 years of age, and they talked about this being a real issue they felt in workplaces.
I'm just going to take the chair's prerogative and ask a question, if I might.
Yes.
So we often talk about, trust and respect and communication when accommodation is required. But there are probably things that would be useful in a workplace in general to create caring, trusting, communicative workplaces. Did anyone sort of talk about the fact that, to start to focus on these things at the point when you need to accommodate is actually well too late? If you had the environment to begin with, you wouldn't be focusing on these things now. It would just sort of flow out. So was that raised at all?
It did come up on occasion, and I think particularly with existing practices and policies like flexible work hours really make a difference. Some workplaces, although they are ostensibly available to everyone, there really is a sense that people have to get permission to use them. But if people were able to have more flexibility in scheduling, job control came up a fair bit. Anywhere where you have some control over the work that you do and when you do it made it much easier. Work at home came up a lot. As being something that if we trusted workers more to get the work done and all these other things, that they made a huge difference. Work near home came up, and this was something that was coming up a fair bit. It was more of a problem. This sense of I have a job where I have to go out in a lot of different places, and it would really be helpful to me if I worked closer to home. That was challenging because for a number of employers, that's your problem where you live, not mine. It's just made everybody wants it. Everybody wants to work 5 minutes from home. We can't accommodate all of that. So I think moving on the environment, we heard that from some of these organizations that were taking this more biopsychosocial approach, trusting workers. I will say that one comment from someone in a financial institution said something like, we entrust our workers to handle billions and trillions of dollars every year, but we're asking them for doctor's notes. And that seemed just silly. So I think some places are going there, but certainly not all.
We have time for one more question. Anyone want to have the final word? Well, I will then. You had differences in men and women. You had a lot more women than men. Do you think female HR managers handle disability management different than male HR managers? Or in the disability management space?
I think I would really want to look more at that issue before I gave a good answer to Peter here. But I would say the talk was the same across professions. It was, or within a profession, was often quite similar. It was across professions that we heard more differences.
Great. Well, thank you again, Monique.
Thank you.